Well, I did want to again thank Dr. Cowan and the university for allowing us to put on this symposium, and particularly this forum as well. I want to mention too Dr. Huh from epidemiology, the chair of epidemiology, for his important role in this the Hypertension Center. But to set the stage for this and the discussion, I wanted to point out a couple of things on some slides. So the first of this shows a map of total cardiovascular disease by state. And that's very dark, it's not projecting very well, are those states with the highest incidence of total cardiovascular disease, in large part driven by hypertension. And you can see Louisiana is as dark as any state there. If you look at end-stage renal disease or total kidney failure, which also is driven in large part by hypertension, I can't even see Louisiana, it's so dark. I don't know if you can, but anyway, it drives home the point again that kidney disease is extremely prevalent in this part of the country. And then if you look at the causes of the kidney failure, the ESRD or end-stage renal disease, you see that hypertension is listed as some 26% and diabetes 42%, but almost every single patient on that graph would have hypertension, and it would worsen their kidney disease. So some is caused by hypertension, others is just worsened by hypertension. So there's a reciprocal relationship between kidney disease and hypertension, hence the combination of the two in our center. And second, if you look at how we're doing in this country in terms of hypertension, as a final slide, this slide shows the current status of the more than 60 million Americans with hypertension. And you can see that roughly in a quarter are aware that they have hypertension but are not on treatment. Another quarter are unaware that they have high blood pressure. A quarter are on treatment and are controlled, but another quarter, and I've just rounded out the figures, are on therapy but are not adequately controlled. And anyway, I thought this might illustrate the dilemma that these diseases represent and why it's important to address them, particularly locally but nationally as well. I think for the panelists who I want to turn the program over to predominantly, I think I'll have them introduce themselves and where they're from and what their role is there and what their take is on this, what we've labeled as an epidemic. And maybe we'll start with Dr. Briggs on the far.
Okay, my name is Josie Briggs. I'm a kidney doctor, and I lead the programs at the NIH in one of the institutes called NIDDK on kidney and neurologic research. The data that Lee has shown is data that has been generated by a large program which has been run through my areas of responsibility, which collects data on kidney failure for the entire country, called the United States Renal Data Survey. And Lee and I have had many conversations about this epidemic of kidney disease. And so we're really delighted that people at Tulane are wrestling with what we can do about that.
I'm Bob Alpern. I'm the dean of the School of Medicine at Southwestern Medical School. And I was chief of nephrology before I became dean. Being in Texas now, I can tell you that usually when I see these charts, Texas is always the worst of any state, so I was surprised to see that we're actually not that bad in this category. There's clearly an epidemic of kidney disease that's occurring and that's going to get worse, driven by hypertension and also driven by obesity, which is what we're seeing across the country, but especially in Texas. That hits us very hard. And I don't think we've actually seen the effects of it, and the synergistic effects of diabetes and hypertension are well known. So I think as our children sit in front of their computers and play electronic football instead of real football, what we're going to see is that they're all going to be predisposed to hypertension and diabetes. And I think the epidemic is going to be very bad. I'll just say from being here today that I was really impressed with the talent that's here and what the faculty here can contribute to addressing this problem.
I'm Teri Manolio. I'm a general internist and an epidemiologist, and I direct the epidemiology and biometry program at the National Heart, Lung, and Blood Institute, which is a sister institute of the Diabetes Institute. We focus primarily on cardiovascular disease, also lung and blood disease, and hypertension we recognize to be a major contributor to the epidemic that is fortunately somewhat in the decline in coronary disease and cardiovascular disease, but seems to be a bit on the increase in terms of kidney disease. And I agree with Bob that the work that's going on here is extremely important in understanding the causes of that and in really sort of following through a group of people and trying to identify risk factors for it. There's a new cohort that's been established here that's studying specifically renal disease, the chronic renal insufficiency cohort funded through Josie's program. There's the Bogalusa heart study that's been here for 30 years and really looking specifically at the development of obesity, hypertension, abnormal lipids in that in children as they become young adults. So a lot of exciting things going on here, but as you've seen, an awful lot of work to be done.
Well, I'm Jean-Marc Lalouel. I'm trained in medicine and genetics, and I came to become interested with hypertension because I was interested in identifying genes that underlying predisposition to common disease in general. And in the area of hypertension, we were fortunate enough to identify that indeed difference in a single gene would indeed appear to predispose to essential hypertension, and we're trying to understand the mechanism underlying this, accounting for this predisposition, and we have pushed the limit, of what we can do at this time at the molecular level. And we have also developed an evolutionary concept that is interesting in the sense that we're trying to understand how is it indeed that genetic susceptibility can exist for conditions that are very common. Because if it is not advantageous, you may wonder how such genes could have arisen at such frequency, and we may discuss that a little bit later. So I've come to essential hypertension through research from the angle of genetics and the underlying determination that can be contributed from that part of the equation, the other one being evidently the environment.
Thank you. I want to now turn to see what questions the audience has. So let's utilize our experts that are here and see what questions you have about these areas.
I have a family history on both sides of my family of diabetes and hypertension. And I'm wondering what you think about how much of that relates, or my risk relates to genetic factors, and how much relates to lifestyle choices. And the second part of the question I have is, if you think that lifestyle choices plays a big part in it, which ones are the most important to focus on? Is it what we eat, what we drink, what we do as far as exercise?
Could you tell us one thing? The people in your family who have diabetes, did they develop when they were young or when they were older?
Adult onset, later in life, usually with obesity.
Well, I'll start, and then the rest of the panel can add to that. I do think the lifestyle choices are very important. And certainly doing your best to maintain an ideal body weight and regular exercise has enormous impact on diabetes. I also have a lot of diabetes in my family, and in my family it's really pretty clear that as long as we're skinny, our glucose handling's okay, but I became diabetic when I was pregnant. Gestational diabetes is what that's called. my brothers have had diabetes when they became overweight. So the data on this is pretty clear. In families with this tendency, you can do a lot, which is maintain ideal body weight. Somebody else should probably talk about the hypertension piece.
Well, I'd be glad to comment. I think you're right that there are certainly genetic factors that contribute to this as well as lifestyle factors, and we all need to recognize that. I think one of the things that concerns us in genetic research is that people get the idea that if you have the gene or a gene for something, it's inevitable that you'll develop it, and so there's nothing you can do. And there's a lot you can do. In the first place, we can treat hypertension. We can treat it extremely effectively with very inexpensive drugs that have very few side effects. And yet, 24 to 30% of people in this country are controlled in their blood pressure, so 70% are not controlled. That's a choice just as much as what you eat and whether you exercise and those kinds of choices. I think in terms of the choices that are important, recognizing that you're at high risk should make you focus on the things that you can do something about. And if you have heart disease or diabetes and that in your family, you can't do anything about that. It's there. You can't choose your relatives. You can do a lot about the other risk factors. And as Josie said, maintaining a normal body weight, getting out and exercising, and it doesn't need to be the Nautilus. I mean, it's, a walk around the block or a hour walk every day is really all that we're asking people to do. And it really does not only in maintaining a normal weight, but it also changes the way that you metabolize things. Your muscles operate differently. You're more sensitive to insulin. There are a lot of benefits, and you feel great. One of the few things we can do for people that really makes them feel better is get them to exercise. They feel wonderful about themselves, and it's a very good intervention. So people who have a family history of these diseases really need to pay attention to managing the things that they can manage, and getting out and getting some exercise, trying to maintain a normal body weight, and controlling the risk factors that can be controlled are critical.
One of the things we hear all the time about hypertension is if you're overweight, lose the weight through both dieting as well as exercise. When it comes to dieting, there is an entire industry out there about how to diet appropriately. Would you comment as researchers about what the research data says if you're really going to lose weight for the purpose of lowering your hypertension? What are the keys you really should follow with respect to dieting?
I may actually ask Dr. Welton to comment on that because he's done a fair amount of work in that area. This is a tough one, and as you say, there's a whole dietary industry out there. The diet industry, frankly, is involved in making money, and there are things that people get into that are fads or that are attractive to them. They can make a lifestyle change for a week or two because it's new and unique, and gee, let's give this a try. The biggest problem in obesity control is not initial loss of weight, which basically the main goal is just to eat less and still have a balanced diet. So reduce your caloric intake 500 calories a day over what you normally take in. We'll give you a safe weight loss as long as you're exercising and maintaining your physical activity. The problem is keeping that weight off. We don't really have good ways right now of addressing that. It means lifelong lifestyle changes and increased activity, and that's very, very tough to do. But Paul, I'm sure, has the answers to this problem.
I don't have the answers. I would echo what you said. Sustainable weight loss is, of course, the key. And it's a matter of preferences, trying to find lower calorie density foods that are fun to eat, and at least for me, getting plenty of those, and staying away from the fads and having a sensible, balanced diet and coupling that with, again, sustainable exercise. And it's a matter for each person trying to fit into their lifestyle. And Scott, you have a particularly difficult lifestyle to fit these things in, but it's a matter of working to try to fit these things into a lifestyle. And they're difficult, but they're manageable. I think the trial data, as you probably know, is not particularly encouraging. That is to say, it's relatively easy with behavioral approaches to achieve weight loss early on. It is relatively difficult to maintain that weight loss over time, although some of the weight loss is maintained. As a society, I mean, one way to approach this is short term, or at least it's a behavioral approach. The second approach is the more classic public health approach, and that's going to source and either working through encouragement, pressured encouragement, or indeed policies and procedures at a federal level to work with the food industry. Our biggest problem is indeed the food industry. That is, they want to make money, they advertise products, they are calorie-intense products, they are made to look very attractive, and I think in the end, as a society, we're going to have to come to grips with this, and we're going to have to approach this from a societal viewpoint of changing our food chain. That's why we're in trouble right now, and it's not going to easily be reversed. Just the last thing I would say on the behavioral approaches, I think we know from a lot of experience, whether it be changing smoking patterns, any health behavior, that when people are sick or when they are at an age when they're likely to be sick, they are highly motivated. And for the person who is the family member of somebody who's just had a myocardial infarction, we know that simple advice from a healthcare provider, particularly a physician, that says, you must stop smoking, has a 25% success rate. Just that simple message. And on the other hand, when you go to talk to kids who have no concept of that they'll ever get sick, a health message has absolutely no impact. So behavior works very well in people who are highly motivated and people who are in a sick milieu, and works very poorly for most individuals in the population.
Let me follow up one thing with that, since we have sort of the world's expert on acid diets present, and since the dietary does lead into the current question of the Atkins diet. Dr. Alpern, what do you tell people that ask about, they say they do lose weight with the Atkins diet or related diets?
Yeah, so I'll just say my own belief is that different people have different genetic predispositions for what type of diet will work for them. And I think just because your neighbor finds that one diet works for them, it may not work for you. So I do think you need to be prepared to move. If one diet doesn't work, try another one. And I think, as Paul's saying, the key is it has to be a diet that you'll stick with, that you actually can live with. So if you're president of the university going out for dinner every night, it better not be a diet that says skip dinner. And what I've seen some people who go on the low-fat diet and lose a lot of weight, and I've seen other people where a low-fat diet does nothing. The Atkins diet, to my mind, made little sense, but actually I've been very impressed how much it works, just from seeing how many people have gone on the Atkins diet who have been unable to lose weight and have lost a lot of weight. And at least some of them have stuck with it. The problem that Lee's referring to is the Atkins diet is a high-protein diet. And what that means is that it generates a lot of acid. So protein, when it's metabolized, forms acid. You wouldn't notice that it's forming acid, but inside your body it's metabolized to acid. And what the acid does is it goes into your bones, and your bones leach out calcium. And acid causes certain changes in urine composition that Lee's research studies, which cause calcium in your urine to be more likely to precipitate. And what we are seeing is, for patients on the Atkins diet, a big increase in kidney stones. And the other end of that, which we haven't seen yet, is it could, in theory, lead to an increase in osteoporosis, because other conditions that have increased dietary acid have been associated with osteoporosis. So if the Atkins diet ever became successful and really took hold in this country, there could be an epidemic of kidney stones and osteoporosis. will probably be protected from that because patients won't be able to stick with the Atkins diet.
Well, I just wanted to further elaborate on the same point. From the standpoint of the geneticist, the reason we get into this business is evidently not to change the genes, but we believe that people's response or the effectiveness of specific intervention depend on the underlying genetics that predispose you to disease. So the perspective we have in long term is to bring about a personalized medicine where you would not necessarily prescribe this or that diet to everybody, but you would try to identify what is most effective and most likely to reduce the risk of disease in this one individual given his genetic makeup. So, for example, in the case of hypertension, one of the issues is who does benefit from a reduction in sodium consumption? Well, probably not everybody. And in fact, in the studies that are based on the genes we're interested in, depending on the genotype you have at this gene, you're going to respond favorably or not to sodium reduction. Not everybody responds favorably. And then you understand the benefit of having a personalized intervention as opposed to mass intervention, which is effective in some people but frustrate others for no specific benefit.
Dr. Navarro, earlier you had a question or a comment.
This is one of my pet areas of interest as well, and we teach the freshman medical students, and I continuously am amazed that we actually do not have very much in the entire four-year medical curriculum that teaches physicians how to adequately cope with their patients who have simple questions about diet and lifestyle changes. And this is one of the things we have to change. But the point is that the average American is bombarded in many different ways with information. Some of it is good, and a lot of it is not good. And quite often, the average citizen is not able to cope and make the distinctions between what really has a strong basis in fact and what does not. They go to the physicians, and quite often the physicians realize that they're really not as well trained as they should be. So perhaps one of the things we also have to set as an important target is adequate training of physicians to really understand dietary aspects, behavioral changes, the various diets that are available, and what works and what doesn't work. Quite often, we do have the answer that simply says, well, why don't you eat less if you want to lose weight? And we know that that doesn't work. And we're going to have to, I think, educate our physicians to cope better with dietary advice to their average patient.
I want to just follow up, first of all, with just a comment and then a question. First of all, Teri, thank you for asking Paul to answer that question, because all these years in our private sessions, he's been saying, Scott, the way to handle your hypertension is keep eating more and you'll feel better. So I'm delighted that you finally made him come clean in public about what I really should be doing. Now I'm questioning the advice my own senior vice president has been giving me. This morning, Josie, I heard you in your presentation. I had the privilege of hearing you, and you started off by talking about how kidney disease, the frequency of kidney disease has really escalated. Right. And I assume that's true of hypertension also, or maybe not. But at least in the case of kidney disease, I was surprised to hear that, and I think the audience would enjoy why. Why all of a sudden, in this day of modern research and technologies and drugs, is kidney disease getting worse?
Actually, Dr. Mautner, who's here, has done a very nice analysis of this issue. Certainly one of the things so cardiovascular disease is declining somewhat. Hypertension, as Teri just indicated, is holding at approximately steady. But diabetes mellitus is clearly increasing. And the biggest reason that diabetes mellitus is increasing is that more Americans are obese. And as we've already talked about, a big determinant of adult onset diabetes is excess body weight. So that's one of the big drivers of end-stage renal disease increases. Now, only a small portion, maybe 20% at the top of individuals with diabetes seem to be susceptible to its impact on the kidney. So 4/5 of diabetics will have diabetes their whole lives, may have terrible control of their diabetes, but still don't develop kidney disease. So again, we're coming back to there's something in genes. And in fact, we're engaged in several large studies that are trying to untangle what it is in genes that makes those diabetic subjects who actually get the kidney problems, what makes them susceptible, or what protects that other 4/5. What can we learn from the 4/5 of individuals who are protected? Dr. Mountner's analysis, which was published a few months ago, and he may want to speak to this, suggests very interestingly that diabetes does not tell us the whole story. And he also looked at another issue which we had wondered about, which is we know that the rate of death from heart attack is actually going down. Maybe people aren't dying of heart attacks. They're living longer and they're getting kidney disease. Well, Dr. Mountner's analysis suggests that's only a modest factor. I think he should speak to this research. It's very nice work.
Okay. Thank you. Well, thank you for the compliments on the work. And I think that what Dr. Briggs says is important, that diabetes, while explained about a third of the rapid increase that we had seen in kidney failure, there's a lot of other things going on. And one of the key points that we looked at was people are surviving longer now and the impact that played. And on the one hand, what we saw was the increased and improved survival in heart attacks and strokes, which obviously we think is we know is a great thing, that people are living longer and surviving these bad events, is not explaining a lot. But the fact is, a lot of people are older, and we're seeing a shifting in the demographics, which might be explaining some of this unknown. So there's a lot left to be done in this area, but what we're seeing is a shifting in the U.S. population distribution towards older age groups, which might be responsible, as well as the obesity epidemic. So there's a lot left to be learned, but I think that through this research, we'll be able to at least understand more and get a better feel for the situation.
These are very important questions from a health policy point of view. When the original kidney failure, dialysis and kidney transplantation is paid for as a disease entitlement through the Center for Medicare Services, and it's actually unique. The reason that legislation was instituted, that began in 1972, is that when dialysis started to work and it kept people alive, hospitals across the country were faced with people who were going to die of kidney failure. And and committees were put together in hospitals to decide who was going to be dialyzed. And this was a terrible thing. It was like death committees, and everyone was horrified by this. And so there was a large effort by a number of people who led in large part by Karl Gottschalk, who in some ways was a mentor to Gabby and myself, a leader in our field. Karl Gottschalk and other people across the country got together and said, we can't have this. We've got to pay for this kind of care because people are dying. And when they did those calculations, they then thought that we were talking about perhaps 50,000 people. And now we have 600,000 people being kept alive by dialysis. So it very much exceeds the expectations. And if the country is going to prepare, and the people who take care of kidney failure patients are going to prepare for the doubling, we got to understand what's driving it. So it's very, very, the kind of work Dr. Mountner is doing is very important for health policy decisions.
You raised a very good point, and we have a long-term solution. And then in the short term, I'm just going to throw this out. Obviously, we'd like to transplant everyone. We don't have enough kidneys to do that. We can dialyze. It's imperfect. Let me just ask you to comment, if you would, on stem cells. We have a big investment in adult stem cells, and I'm not asking this to push it, but do you think it is realistic that regenerative medicine will come to the rescue as a mechanism to regenerate organs for us? Is that
Well, this is
a dream, or is that reality?
This is a wonderful question, Paul. And of course, I don't know the answer. And actually, there are other people in the panel who can also comment on this. I think the potential of stem cells to contribute to the ability of organs to repair themselves is looking for the kidney much more promising to me than it looked a couple years ago. I was very impressed by a paper published in the JCI a few months ago which showed that after acute renal failure, a lot of the cells that repopulated the tubules when they regenerated actually came from the bone marrow. These investigators did this work in mice, but it was very elegant work where the mouse was the kidney was transplanted from one mouse to another. Those of us who work with mice know that's a really tricky thing to do, and the mice stem cells were marked with a marker. And the kidneys were then given acute renal failure, and lo and behold, a lot of the cells that were fixing the kidney, that were involved in tissue repair, actually came from the bone marrow, not from the organ. So that gives me renewed enthusiasm that we have to look at the potential of using stem cell-based methods to help tissue regeneration. Most of the work we fund currently that's going on in this area is actually looking at bladder regeneration, and it is looking like pretty sizable progress is being made in the development for patients born with congenital problems with the development of the genitourinary tract, that the possibility of generating a artificial bladder using stem cells may be a little closer. The bladder is a much simpler organ, as you know, than the kidney, which is pretty complex. But those are my only thoughts about this. I think this is a wonderful scientific area. It's an area that's exciting. My first thoughts about it a few years ago were, the kidney's much too complicated and heterogeneous for regeneration to ever be helpful. But I'm really rethinking that.
I'll just add, as the dean at Southwestern Medical School, we've had many discussions about this and have actually placed stem cell biology as our #1 scientific priority for the institution. I think you've probably read this, what the state of California is doing. They're talking about setting up a huge fund so that they can perform stem cell research without being dependent on the NIH because of the concerns about NIH funding. The Howard Hughes is supporting this. We have a long way to go with stem cells, and there's probably a lot of research to be done in mice, for which there are no ethical issues right now. And that's probably where the bulk of our research is focusing. And I think the NIH does fund a large portfolio of that research. There's obviously some concerns with human embryonic stem cells. And right now, any research on human embryonic stem cells is almost empiric rather than really based on knowing what you're doing. But I think the capacity, what could possibly happen with stem cells, could be greater than any other field of therapy, and we need to move ahead with it. And as I said, right now we need to move ahead with it in mice mostly. So we're very enthusiastic about it. And the other thing I would just mention is that even if repopulating the kidney is difficult, although we may make progress, it may be a lot easier to fix diabetes.
Two things, so don't let me forget the second. I've lived 70 plus 7, almost 8, and I don't expect to live much longer because nobody gets out of this really alive. But is there anything short of dialysis that a doctor does for you? I go through a factory every time I go to auctioneer. It's Total Health 65, and I'm also retired Navy TRICARE, so costs have nothing to do with this. I'm just starting. Westerfeld is the name of the doctor, and he's just starting to worry me a little bit about this nephritis or whatever it is. Is there anything short of dialysis that you can take besides losing weight? pills or anything?
Oh, absolutely.
Oh, man, I love you.
So
I don't want to go into one of those mechanical messes.
There are a number of steps that are very important in slowing the progression of kidney disease. The most critical is good control of blood pressure. And second is good control of diabetes, if the kidney disease is related to diabetes. Good control of blood pressure in some cases, for some people, means use of a certain class of drugs which interfere with the renin-angiotensin system, drugs like converting enzyme inhibitors. But that's not the right answer for everybody, but it's the right answer for many patients with kidney disease. And then the question, which I suspect your physician has dealt with, is what actually is the diagnostic category of your kidney disease? Because some kinds of nephritis actually are related to activation of immune responses. And those kinds of kidney diseases, in some cases, require special therapies that are directed at the immune system. That's a start. Maybe Bob, who's also very expert on this, will want to add to the many things we do for kidney disease.
Yeah. I mean, I think that I've followed a number of patients where I think I've made a significant difference in the progression of their renal disease. Just, if nothing else, working with weight loss, low salt diet, making sure blood pressure is under control, converting enzyme inhibitors, which is a type of drug that turns out to be useful in many forms of kidney disease. And I think you have profound effects. As a matter of fact, one of the issues that Josie commented on this morning, when you do these long clinical trials with patients under close supervision, the problem is the progression of renal disease becomes so slow because the physicians are taking such good care of the patients in the clinical trials, and which makes it hard to show a drug effect. But I think, to me, there's very clear evidence that if you have renal insufficiency and you're a good patient with a good doctor, then your prognosis is much better.
There are also some complications of kidney failure, like bone disease and cardiovascular disease, that by anticipating them and making sure the therapy is correctly adjusted, the problems associated with kidney failure, even if the kidneys fail, can be made much less. So you probably want to talk to one of these Tulane docs.
Well, I was going to put in a plug for it. I couldn't resist.
That's the first question I asked the doctor. I said, "Are you a Tulane man or 4-lane now?" It used to be Tulane when I went here. But he never did answer me. In fact, it's like a factory at Oxnard. There's so many people going in and out of there that they don't have time to ask you if you have any questions. And if you do, if you're my age, you can't remember what the question was. But the problem is...
Second question.
You can pick up your check at the...
Second question, I noticed on your topography there about the high density of black. You couldn't even see the Gulf of Mexico. Have you ever done any work on... I've been on chlorinated water ever since I started up in Ohio. And as that Mississippi River comes down, it looks like the density of that blackness gets greater and greater. Have you ever done any work to see whether all this fluoridation and chlorination has an effect on the kidneys? Give you something to think about. That's the way an engineer looks at it, not a doctor.
Do we want to turn this one to our epidemiologist?
Well, I can certainly agree with you. The Mississippi Valley has long been known as an area where cardiovascular disease and many other forms of diseases cluster. We're not sure why that is, but if you look at maps of mortality, stroke mortality, cardiovascular disease, it comes down the Ohio River, comes down from the Missouri, and meets, and you can follow it right down into the Gulf. Part of that is probably socioeconomic. Poor people do tend to live along riverbanks and that, but there are probably other things as well, and we don't have good answers for it. What we can do is say, all right, these are areas that are high risk. This is a place we can target and really try and get other risk factors for kidney disease and hypertension and other things under control. And there are efforts being made along that Valley, basically, to do exactly that and to really make sure that the messages of prevention get out to the communities that need them the most. But no, we don't have good reasons for that. The fluoridation and chlorination have been looked at, haven't really seen much in the way of relationships of those. And they are wonderful for your teeth. And having teeth is wonderful for eating a good diet. So I would say go ahead and drink the water.
We've been hearing in the last half an hour the term obesity appear over and over, its relationship to the risk of hypertension, diabetes, kidney disease. And we've touched on this issue of the popularity of the Atkins diet and how that may not be the answer to long-term weight loss. I would like to ask the panel to comment on sort of the newest wave of weight loss for the morbidly obese, and that's gastric bypass or gastric banding, and what might happen to society if this becomes the quick fix for many people. It's become a very simple surgery. 2 days in the hospital, laparoscopically, promises long-term, lifelong, tremendous weight loss.
Well, I'll try, but this is not an area I'm expert in. I think the impact of bariatric surgery for morbid obesity, the literature has been very suggestive that there is truly benefit for individuals with extreme obesity. The NIDDK has begun a study to try to look at that more rigorously, and this is a registry in which information will be collected prospectively on subjects who undergo this procedure. I can't comment in detail on the design of that study. I know that it is focusing on individuals who are very obese. Individuals, I believe the BMI cutoff is going to be 32. But this is really pretty extreme obesity. And I think that that study is intended to increase the amount of rigorous data on what the risks and long-term benefits are of this intervention. I share the hesitation implicit in your question about this as a treatment for what you might call cosmetic weight problems. And I think that the people who are designing this study are attempting to get at the issues related to the use of this procedure for more severe weight loss, which certainly many physicians have become increasingly comfortable with. But I think this is a tough issue and it's an important one.
I would just add, because we've been talking a lot today about diet and the American diet and lack of exercise being a cause of obesity. It's important to remember there's a strong genetic component to obesity, and there are some people who unfortunately have genes that there is nothing that they're going to be able to do with diet, even if they follow it, that will be able to prevent their obesity. That's what bariatric surgery was developed for. It was for those people. I certainly never intended to replace diet. I actually remember a number of years ago, I took care of a patient. There were identical twins, and the twin brother was about 150 pounds. It's slim, and his brother got in an automobile accident and damaged turned out to be the feeding center of his brain, and he went up to 450 pounds. And there was nothing he could do to stop weight gain, and he eventually died. So there is an organic basis to this, that if you inherit the wrong thing, in this case he didn't inherit it, then there really is nothing that you can do about it. And then I think bariatric surgery is a lifesaver, but it certainly should not be used lightly and has a lot of complications.
This question, as far as obesity, there was never any in the concentration camps, so I wonder about the genetic component. I don't know how else to state this.
I guess what I would say is you do have to eat to get obese, but some people don't have to eat a lot. And in this patient, for instance, he was just continuously hungry. So sure, if he was in a concentration camp and there was no food, I guess he wouldn't have gained weight. But with any food around, I mean, if you think about it, trying to resist eating if you're very hungry is hard. And if somebody's very hungry more often, it's harder.
Yeah, there is a... Sorry? Sure. There is a perception that I think may be a misperception that people who are very obese are, reckless eaters or are irresponsible or whatever. And I think we need to get past that because there are issues related to current American lifestyles that make it very, very difficult, as we talked about earlier, for people to be able to live the way we evolved, which was eating 5,000 or 6,000 calories a day. I mean, we used to, normal caloric intake for me is supposed to be 2,000 calories a day. Probably to maintain my weight, I actually need to eat about 1,500. And I'm hungry at 1,500. There's no doubt about it. But it's because I'm not out chasing after, mastodons to get my dinner. It gets brought to me. I can sit at my computer all day and then, poof, there's food. So we've changed, and our culture and our environment have changed dramatically. Jean-Marc can give you chapter and verse on this. And yet, our genes and our metabolism have not. So we are going to need to find some creative ways to deal with that. Bariatric surgery, I think, as was pointed out, is appropriate for people who are rare and have extreme forms of obesity. But there are other ways of dealing with this. Reducing the caloric density of foods. We have wonderful ways now of making foods that taste really, really, really good and are incredibly calorically dense. And, studies have shown that if you put in front of people a certain amount of food, regardless of the caloric density, they will eat it. So there are ways to reduce that. Vegetables are a great way to do it because they don't have much density. They've got a lot of fiber, and so there are other options, I think. Do you want to comment on?
Well, I don't know if I want to go with my most spiel about the fact that much of what we manifest nowadays are the result of ancestral genes that were definitely advantageous at the time where substance we were looking for were scarce. And this is true for sodium. This is true for general caloric intake. A lot of what we have now in abundance was very scarce at the time. And to develop a genetics that would allow you to survive under such conditions and be able to concentrate a rare substance in nature was very advantageous. So indeed, I was talking about that this morning. What the kind of scenario that is emerging is that the genes that predispose to common conditions such as obesity, hypertension, and diabetes, they may actually be the ancestral form of those genes. They may be actually what was of adaptive value in a certain environment. But because of a rapid cultural change and, abundance and affluence and the consumption of processed food that are rich in sodium or, in energetic substance, we have all of a sudden those genes that were quite advantageous become actually a disadvantage. And they are what actually predispose to those common diseases. And interestingly enough, there is evidence, indeed, marginal at this time, but yet in the kind of studies we're doing, there is evidence that the gene that would actually protect against the harmful effect of affluence and abundance are actually the novel form that have appeared recently. And they are actually getting more common. And eventually protection will happen. And much of the story was that culture changed very rapidly, but genes changed very slowly. And although our genome is adapting to new conditions, it takes tens of thousands of years to get the genes to reline up with new environmental conditions. And in some of the common diseases that we see, we may actually be seeing the shift that has happened with the diaspora out of Africa. I mean, the move out of Africa may be actually explaining some of what is happening with sodium sensitivity worldwide. And there may be very more recent effect of refrigeration and other things that have come up that are completely changing cultural, the cultural condition in which we are. And unfortunately, those genes don't evolve much. What we do hope to do with the genetics is to identify, as I was saying, individual predispositions so we can have personalized medicine, not only in terms of intervention, but possibly in terms of targeting of specific drugs. The problem of hypertension is that we have a series of drugs that each are affecting a subset of individuals, and we cannot identify which individual respond best to which type of drugs. And we would like to have this adequacy to be made simpler by identifying underlying genetic mechanism in any one individual. So from our standpoint, we look at both sides. We look at both the cultural, the lifestyle, and we also look at the genetics. And I think that the intervention that the individual would like to apply to themselves is the one that will be most suitable for their underlying genetics. And this is the hope of the geneticists, that down the road we will understand more about the underlying predisposition to common disease. It's obviously complex arrays. It's not as simple as the classical single gene disorders. It's a number of different diversity that is among us, that is of adaptive value, that represents strategies that in the past in different ecological niches were good strategies and adaptive. And now that we're just a broadly mixing population, combination of certain of those genes may prove disadvantageous. And we hope that we can be able to identify some of that. So there's a risk coming from both sides, right? The geneticist is trying to identify individual genetic difference. And from a standpoint of epidemiology and clinical prevention, the attempt to identify what is the best strategy that can be targeted for a given genetics.
Lee?
Yes.
I just wanted to take just one moment to tell this audience about a wonderful study that's going on here at Tulane, which has been mentioned briefly in the introduction, but which perhaps some members of the audience would be interested in. This is a study which is called the Chronic Renal Insufficiency Cohort Study, and Dr. Ha here in the front row is the leader of that study. And this is a study that will follow a group of people with mild kidney problems for initially a period of 6 years, but potentially for 12 years or so, to try and get at some of the questions that have been raised in the discussions today. And patients who choose to enter that study will come to the site once a year, have a set of studies like an EKG and blood pressure determination, and perhaps in certain selected cases some x-rays. They'll have blood samples and urine samples stored. And we believe this will be a national resource for looking at some of the issues that we've heard talked about today.
Seeing no other hands of questions, is there one? Good.
Do the statin drugs have any positive effect on hypertension or renal disease?
Others can comment as well. The statins have other effects other than the lipid lowering. It's not clear what exactly those are. They do seem to have some effects on inflammation, on perhaps the vulnerability of plaque to rupture and to cause a heart attack. I'm not aware of them having an impact on blood pressure, if anyone else is aware of that. Yeah.
Statins, the abnormalities in lipids do appear in certain animal models to make kidney disease get worse faster. And there are several studies going on internationally, one in Europe, that is looking at whether statins would be helpful for the progression of kidney disease. Right now, there is not. Statins are useful drugs, and people whose lipids are abnormal should take them. But whether people should also take them just because they have kidney problems, we don't know yet.
But there are good animal studies that show that in animals that lipid-lowering agents slow the progression of renal disease. And the issue
But there are many examples, as Bob, I think, will admit, where interventions have helped mice or rats but haven't helped people. So before we're ready to recommend statins for their kidney indications, that's not, they're useful drugs when the lipids are abnormal and indicate their use. But whether you should also take them just because, or I shouldn't say just, but if your kidney function is a little bit abnormal, we don't know yet.
I agree.
I'd like to ask the panel a question on circadian changes in blood pressure. I'm one of these hypertensive patients. 8 months ago, I got on some therapy, and I've been monitoring my blood pressure. I'm retired. I can do it several times a day. And I'm just amazed at I'll have 20, 25 points difference between a reading in the morning and a reading in the afternoon during a day when I don't feel any stress or any factors that could contribute to that. And I was very interested in Dr. Alpern's talk this morning on circadian rhythms, and I was wondering whether there's such a thing in terms of blood pressure in humans.
Actually, yeah, I'm going to let these people who know the data. But yes, there is. And blood pressure, obviously, it goes down at night. And the question is, if your blood pressure doesn't go down at night, what's the effect of that on morbidity and mortality? So there's a well-documented circadian rhythm of blood pressure, and our definitions of what a normal blood pressure is are probably naive in that respect. But I think we can hear the data.
Well, I don't know that we're aware of lots of data. There are what Bob is referring to as 24-hour ambulatory blood pressure monitoring that has shown, in numbers of studies, that there is this tremendous variability, and that the variability, even though it sort of jiggles, it goes up at certain times and then it goes down at certain times, particularly at night. When you're asleep, your blood pressure should be at the lowest that it reaches, and if you don't lower your blood pressure when you sleep, you're at much greater risk for complications of hypertension. There are a variety of endocrine and neurologic reasons for those rhythms, and I'm not a sleep specialist, so I can't tell you much about them. But I think that the bottom line from this is that when we've done studies to look at the relationship of blood pressure to cardiovascular disease, we've done them pretty much measuring the blood pressure, at random times during the day. And if you do that enough, you do get an average, and that average pretty much predicts what your risk is likely to be. So there are times it's going to be high and times it will be low, but you pretty much, vary around a mean, and that mean does predict your risk.
Yeah, this nocturnal dipping seems to be a good thing. And so the fall of blood pressure when you sleep is correlated with lower rates of certain diseases. The Crick study actually anticipates doing some ambulatory blood pressures, and we will certainly learn something from that as to whether ambulatory blood pressures predict kidney disease risk. And there's a little bit of data that the failure to have nocturnal dipping may be associated with more disease. Now, just in practical terms, if I were your doc, I would say, well, you really don't want to measure your blood pressure right after you've run up a flight of stairs. And so you do want to make sure that this variation you're seeing is not related to exercise. It should be done when you're relaxed and in a resting state, because the variation may be immediately related to exercise and not have quite the same meaning. Another issue that comes up in the management of high blood pressure is where the blood pressure, whether the drugs you're using are giving adequate coverage throughout the day. And some drugs are better for longer term management, and some people may metabolize drugs a little more rapidly. So there are many parts to an answer to your important question.
If I may add actually something that, some evidence that comes from the mouse, where I have more experience than in the human. In the mouse, indeed, there are circadian rhythm in blood pressure, and we have ways to monitoring it even better than in human, because we implant device such that through radio frequency, we continuously measure blood pressure. And through those continuous measurements, we also can measure activity. And it is very clear there is a circadian rhythm for blood pressure, even upon correction for activity. So it's not just the activity that drives the circadian rhythm. In these animals where we measure activity, we can regress out the effect of activity, and they do have a circadian rhythm that's very reproducible, and it definitely corresponds to hormonal cycle that they have. And we're not that different from those mice, from a basic standpoint. They do business basically the same way we do.
Well, this morning I gave Navarre some anecdotal information on myself that he laughed at me. But I discovered a couple of days ago that if I'm sitting at the breakfast table and I take my blood pressure, and let's say it's high, it's 160 over 90, and I take 10 deep breaths, hyperventilate, I can bring it down to below 140, and 140 over 80. Yeah. And
Yeah.
Is that real, or is it my imagination?
Sure, that's vasodilation. I mean,
Yes.
your circulatory system is a responsive organ, and it's there to help you run away from saber-toothed tigers and do other things that you needed to do when you evolved. And absolutely, it should change when you do a variety of things. When you get stressed or anxious or angry, when you're cold, your blood pressure will go up. There are a lot of things that will do that. And hyperventilation lowers the CO2 in the blood, which is a vasodilator, and so the blood pressure would come down. So I'm not surprised.
You mentioned that when you get stressed or angry, your blood pressure goes up, and I was actually wondering how it correlated with anxiety and depression. How does hypertension correlate with those diseases? I would imagine it correlates very favorably.
Yeah, I'm embarrassed to say I don't know that literature as well as I should. If there are others in the room that do, please speak up. I think there have been studies showing a relationship between both of those, both anxiety and depression. Shake your head if I'm saying this wrong, but it's not a strong effect. It's not very large, and you get more of a relationship with blood pressure in acute anxious episodes such as panic attacks and that, where you have this tremendous surge of sympathetic stimulation, basically, and blood pressure can go up quite high. But on a more chronic level, there may be small differences in blood pressure, but they're not major.
It's very important to keep in mind that if you're a very relaxed person, it doesn't mean you have normal blood pressure. The term hypertension is the worst name they ever could have given to high blood pressure.
Hence the term silent killers. Well, I think looking at the hour, we do need to wrap up. I want to thank the panelists for coming here and for providing a really marvelous exposition of what's going on nationally to address these very important issues. So I want to give a round of applause for them.